today, we're really fortunate to have Dr. Martha Fulford. And I have to read you this bio. It's an amazing bio. She's got a BSc, B.Ed, MA, MD, MRCPC, an associate professor at McMaster. She's an infectious disease specialist. She's also a hospital-based physician, so she's not only an academic, but she sees patients. And the majority of her work is in pediatric patients. In addition to her clinical work, she's also worked in the vaccine clinic for the Shelter Health Network as actually going out in the community and providing vaccines. But something you may not know about Dr. Fulford is that she is a teacher. And prior to becoming a doctor, she worked in Southern Africa for 5.5 years before returning to Canada to go to medical school. So she's not only gives you the doctor, the infectious disease aspect, but she can also give you the academic, the teacher aspect. So we're really fortunate to have her here today. And the format of today is that Dr. Fulford will actually give us a presentation. Presentation will last as long as she wants, probably 45 minutes. Then we'll have a break, and then we'll have a panel discussion. So you have the opportunity to write your questions, whatever questions you have, and you know, you've got the experts here. You got the family doctor, you have the psychiatrist, you have the infectious disease specialist. So ask away, and we'll address your questions. And if there's something that they can't answer, I'm sure they'll find the answer for you. Without any further ado, let's start the program. Dr. Fulford.
So thanks again for asking me to speak. And my only point is to let kids be kids. And I have been saying that I have no conflicts of interest of any sort. I have no external funding from anybody. And I've recently realized I have to point out I have no political affiliations because I've been accused actually apparently of representing one or other political view when I advocate for children, and I don't think that advocating for children has anything to do with politics. So what I want to do is actually place us where we are now with COVID and a little bit of the impact on children, discuss a bit about schools, what's happening when we're not letting our children be in schools, and the atmosphere in our schools as well. I have been asked to touch on the whole role of vaccination and pediatric vaccinations, just touching on treatments. That's not really the role here. And some of my thoughts on how we can pivot to a new normal. One of the challenging issues in this conversation has been this question of are schools safe? And I find it really unfortunate that we start with the supposition that somehow schools are intrinsically unsafe. I'm not even sure where this came from. And then the question is safe from what? Because again, this is very ill-defined, and you can never be safe enough if you have no endpoints or no conversation about what it is we're trying to avoid. And I keep saying, well, where are the studies? Where's the data? On what basis are we saying that, for example, in Ontario schools are unsafe when we look around the world? So I'm going to start with just reminding us of coronaviruses, because I think we get so enmeshed in some of what's happened over 2 years that to take that step back is helpful. Coronaviruses are well known. They are a common cause of respiratory tract infections. They're found not just in humans, but a whole lot of animals and birds. The word corona actually comes from those little spiky things around them that look like a crown. It's a Latin for crown. First identified in birds in the 1930s, the first human ones in the 1960s. And I think most of us know by now that there are 4 circulating coronaviruses that circulate every year. During respiratory tract season in the winter, coronaviruses were a common cause of respiratory tract infections. Obviously, we have the new ones that have been more recently discovered now with COVID-19, of course, and I'm sure there'll be others we identify in years to come. This graph is actually the coronavirus seasonality pre-COVID. It's a study from Michigan. It looked at what happened with coronaviruses over an 8-year period. And you can see pretty clearly that there is a seasonal spike, December through to about February, depending on which of the 4 strains. When we look at COVID era, they were responsible for in the range of 5 to 10% of upper respiratory tract infections, in other words, the common cold. And some of them, for example, OC43, when it hit a nursing home, there could be mortality as high as 8%. This is a study from Melbourne in Australia. There have been other studies that reported as high as 15% mortality in a nursing home or long-term care facility if one of our seasonal coronaviruses got into them. So then we come to COVID-19 and our current situation. I'll come back to the clinical. So this is what's happening right now with coronaviruses in Canada. These graphs are the Public Health Agency of Canada website. I don't think anybody can doubt that we've got a huge spike there. But what's important if you look at the bottom graphs is that's the hospitalizations, how many people are in an intensive care unit, and how many people are actually on mechanical ventilation. Now, there's obviously an increase in people admitted to hospital. But remember, this also reflects the community cases, and many of the people admitted to hospital are incidentally positive because we screen everybody. Much more important is if you look at the people in ICU and vented, you can see a clear dissociation or decoupling of what's going on in the community and what's happening in our hospitals, which is different than the spikes with every other wave, because if you look at, for example, the ICU spikes, they pretty much match what happened in the community, whereas we have a complete decoupling now. What's circulating at the moment is Omicron. Again, this is Public Health Agency of Canada. This is at the end of December, and probably now we're pretty much all Omicron, but maybe with a little bit of Delta still circulating. And this is what happens with viruses. You do get variants that come and go with each season. It's certainly what we're used to with influenza. So what has COVID done to us? So these are the numbers of, sorry, let me go back one more. This is sort of, our graph, epidemiology, all these cases. It's a thing we've all been obsessed about for 2 years. But this is data from British Columbia. It's looking at the top 15 causes of death from March of 2020, from the beginning of the pandemic, to October of 2021, so a few months ago. Top 15 causes of death in the province. You'll notice that COVID is actually number 9. And you'll notice that the average age of death of COVID is age 82. Again, to put it in context, there's no way to minimize the impact that this has had, but we know a lot now about who's affected and who's at highest risk. The other piece of information I think is important to look at are the yellow bars, because that's actually overdose deaths in British Columbia. And there have been more deaths from overdoses than from COVID, and in a much younger population. So again, not to minimize COVID, but we need perspective on what we're dealing with. If we look at the breakdown by age, it's by every 20-year gaps, there is no question that really COVID as a serious cause of death is really significant when you start to hit the age of 60, there's some in the 50s. But in younger people, drug overdoses kill way more people than COVID has since the beginning of the pandemic. And again, not to minimize COVID, but we need perspective as to what a real risk is and what a perceived risk is. We're not supposed to talk about influenza and COVID. Everybody gets annoyed when you try to compare them. So I'm just looking at pediatric data. And again, in no way to minimize COVID, but to just get a sense of perspective so we understand the risk of COVID compared to the risks of other things we deal with. So the influenza data from 2018, 2019 is from Flu Watch. Anybody, you can look it up. So I've reported annually. The age group is 0 to 18. You can see how many hospitalizations, ICU admissions, and we had 10 deaths that year in pediatric deaths from influenza. Look at the COVID numbers. It's a slightly different age group, and this is for the whole pandemic. From January, from the beginning of the pandemic, should say 2020, sorry. So at the very beginning of the pandemic until actually it was January 7th, the Public Health Ontario of this year, Public Health Agency of Canada data. It looks like we've got almost twice as many numbers from COVID compared to influenza. Remember, this is 2 years versus 1 year. But something about the COVID numbers is that this counts anybody who's tested positive who's landed in hospital. And we have a group in Canada called the Canadian Nosocomial Surveillance Program. It's nosocomials are hospital acquired. And in reviewing all of the pediatric admissions, what's clear is that only 56% of them were not because of COVID. So COVID was incidental. So just over half. If you go back to these numbers, that means only about half of the COVID numbers are because of COVID and the rest was incidental. So what I'm showing is that the impact on children from COVID in 2 years is essentially the equivalent of the impact of influenza in 1 year. And not that we should neglect either of these, but it's more to put it in perspective with risks that we deal with on, all the time and that we accept all the time. This is data from the CDC. It's looking at causes of death in the United States. And again, not that COVID never causes a child to succumb to the disease, but it's the perspective we need when we talk about the threat to our children. And you can see in the 1 to 4 year old group that actually a child is more likely to suffocate than die of COVID. If you look at the 5 to 14-year-old group, drowning is a much more significant cause of death than COVID. And even in Canada, we think of accepted risks. If you look at our Canadian motor vehicle fatality numbers for 2018, 179 children died in motor vehicle accidents that year. So we have almost, what is that, like 9 times, 8 times as many motor vehicle accident deaths in 1 year than COVID deaths the entire pandemic. And again, it's not to minimize something, but to try to put it in context for people so that when we make decisions, not based out of fear and panic and an exaggerated sense of the risk that we're actually facing with our young people in particular. So coming back to what COVID itself does clinically, coronaviruses, the other 4 coronaviruses, average incubation period 3 days. In adults, caused a typical respiratory tract infection, in other words, a cold. But they could cause pneumonia, could cause a viral pneumonia, so vulnerable adults did get more severe disease. And it was the 3rd most common cause of a viral community-acquired pneumonia after RSV or influenza. RSV is respiratory syncytial virus. So it was, we knew coronaviruses could do this, so in general they're mild. Exactly the same as in children. Very unlikely to have severe disease. If they were symptomatic, it was sort of typical cold, flu-like illness. It's a common cause of viral ear infections, acute otitis media or middle ear infections. And for hospitalized children with respiratory tract infections, coronaviruses cause about 9% of the cases. And there were studies that actually looked at how many children might test positive if we just looked in their noses. And yes, there were kids that would test positive for coronavirus by a PCR that had no symptoms whatsoever. So in COVID, it's basically the same thing. Mild infections, many are asymptomatic. We don't know the actual denominator because when you think of so many kids having no symptoms or mild symptoms, it's hard to know. The estimates in the studies try to get a sense of how many kids have no symptoms versus how many kids are sick, or anywhere from 30 to 75%, so it's all over the place, but because it's challenging when somebody's asymptomatic, how do you count them? There was a study in Italy that looked at antibody levels to see how many kids have been exposed, and in that study it looked like only 18% of the kids who had actually been exposed had been symptomatic. Some of these details aren't important. The point is it's very mild in kids. Some kids are at higher risk of a bad outcome, and these kids need to be recognized. It's severe neurological disease, it's obesity, which is actually true in adults as well, severe underlying lung disease, like the kids who are on chronic ventilators, who are on home oxygen, same as adults. And then the other risk factors are there, but they're lower down. And to give a sense of the proportion, oh, that diagram's not showing, I apologize. Oh, here we go, sorry. So pre-existing comorbidities, you can see on the diagram that maybe 13% of the admissions were because of severe neurological disease. You can see that about just on 10% because of obesity. So it's not that these dramatically increase the risk of being admitted to hospital, but it increases it a bit. And that's about half of them had pre-existing conditions. And these are the kids that are most likely to have a more severe outcome, and it's the first 3 in particular, the ones that are most likely to land in the intensive care unit if that's going to happen, understanding it's rare even with the most compromised of our children. So I'm going to just switch to Omicron. Lots of worry about Omicron. It's very transmissible, but everything is pointing to a much milder clinical disease actually than our previous variants. And it's presenting with much more typical upper respiratory tract infections that we're used to with other kids. So basically it's what Omicron is doing to kids are exactly what our usual seasonal viruses do. And this actually should be reassuring and good news. This has been confirmed in studies. This is a study from the US that looked at just over 14,000 people. Just over a quarter were children. And it was very clear that when people had infection with Omicron, there were significantly fewer severe outcomes and shorter hospital stays as well. This is a headline I saw in from Global News on January 4th. This is a real headline. I didn't make this up. Cough, cold, or COVID-19. Doctors say with symptoms overlapping, it's impossible to tell. And honestly, if you can't tell the difference between a cough, a cold, and COVID, you actually just have a cold. It really doesn't matter what virus is causing it. And this is a psychological shift that we have to accept in terms of our sense of concern. And do we have what some of us are calling a pandemic of positive PCRs? This is a photograph taken on January 14th outside Fairview Mall. So it was actually when the temperature was minus 18. These people are not sick. They're actually lining up to be tested. And pre-COVID, the very idea of entirely healthy people with no symptoms of any sort going and asking for a test to see if they have virus in their nose, and even though they still have no symptoms, being designated a case is simply not something we would have done in medicine. Cases required signs and symptoms as well. And this business of testing and making healthy people become a case needs to stop. And public health is starting to try to do this. We should not be testing asymptomatic people. We should be targeting our testing towards the people who are in hospital, who are sick. And there's a lot of resistance. People kind of become addicted to tests. It's a very unusual situation. But it also falsely, it causes a lot of false alarm, I think, because how many of these huge increases in cases in the community are either have no symptoms or really just have a mild cold? And this is, I think, a very real question we need to ask, because pre-pandemic, there is no way we would have gone around and done viral swabs of everybody in the community with no symptoms to see how many people had virus in their nose with no symptoms. It's not something that we should be doing at this point in time. Maybe at the beginning when there's concern about asymptomatic transmission, but 2 years into this, with what we know and the vaccine rates we have, this is a practice that we really need to move away from. And we need to let people just lead their lives. If you're healthy, and you don't have to think anything beyond that. I'm going to touch a little bit on long COVID, because this is one of the questions that people have a lot of. It's so-called post-infectious syndromes. These do exist. We see them after influenza, we see them after other viruses, we see them after certain bacterial infections. Some of them are really well described. There's a condition called Guillain-Barré syndrome, which is an ascending paralysis, not very common, but it has been described after Campylobacter, which is a bacterial infection. We've seen interesting neurological symptoms after influenza, but they're rare. The question is COVID doing this to us? Because I'm hearing some fairly extraordinary claims about long COVID. So how common actually is it? And in order to know this, we actually need to study it properly. We need to study it systematically. This is a review article in the Pediatric Infectious Disease Journal. They reviewed 14 studies. They took the studies, looked at 14 of them to try to get a sense of how much long COVID there was. These are actually very poor studies, and it's interesting. Pre-COVID, we might not have accepted some of these. Very lack of clear definitions. What is it? You can't, until you know what you're trying to deal with, you really can't study it. Variable follow-up times. Astonishingly, some of them had included kids that hadn't even had confirmed infection with the virus. A lot of self-reporting, a lot of bias. Only 5 of the 14 actually had control groups, so they compared kids that had had COVID with kids who had not had COVID, and 2 of the 5 actually found no difference at all. So the data is not very compelling. This is a study from the UK that's probably a lot better. It's from the Office of National Statistics. They have very good data in the UK, actually. Again, anybody can look up their studies, easily available online. But they looked at just over 26,000 participants. They confirmed that they had PCR positive for COVID. They matched them 1-to-1 with people who did not have COVID in the community. And then they followed them for over a year, from April of 2020 into August of 2021. It included the biggest of their Delta spikes. And they followed them initially weekly and then monthly to track what their symptoms were. They had a very clear case definition. They had very specific symptoms that they had identified as the most common claims for long COVID. And I'm going to just make an editorial comment about this. Pre-COVID, if I had a patient with a viral infection and then that patient had a cough for a few weeks, I called it a post-infectious cough. It happens. We know it's happened. It's very common. It'll go away. We didn't label it something, and I worry a little bit about some of the labeling and making people think that there's something more going on than actually is. Then of this study, they looked at the kids, and if you look at the numbers on the column, you can see, for example, the 2 to 11 year age group. Interestingly, it's actually the children who were the control, who did not have COVID, who actually had reported more symptoms. A little bit of an increase in the 12 to 16, and by 17 to 24, there's no difference at all by sort of the 12 to 16 week mark. And there's another study from France, it was in adults, that actually showed that as soon as people knew that they had been diagnosed with COVID, and compared it to people who might have had COVID but not had it diagnosed, found that the people who knew they had COVID were more likely to report long COVID symptoms. So we're learning a lot, but I think a lot of what we're seeing in children has nothing to do with whether or not they've had the virus, but everything to do with the measures and the interventions that we've imposed on them. So we have to be very careful, we have to be systematic about these studies. But everything that we're seeing on the objective studies is that, do post-infectious syndromes happen? Yes. Do they happen more commonly with any viruses? No. We are not seeing a signal to more post-infectious syndromes than we're used to seeing with any virus. One difference is I think a lot more people have suddenly heard about this. I mean, I, as an infectious disease physician, have seen people with post-infectious syndromes my entire career, but maybe it wasn't as well understood that these things can happen, but they're very rare. Let's move to schools, because that's a lot of what I worry about. There was a study in Ontario in April of last year. They actually went into the schools in Ontario and just did random testing to see whether there was whether they're asymptomatic infections and whether there was maybe asymptomatic transmission going on. There were over 56,000 swabs, 56,183 specifically. This was as of the end of April. The numbers are higher now, but this is the end of April because that's when the big closure happened. They only had 411 positives, so 0.7%. This actually matched the symptomatic cases at that time that were school linked. This is at a time that positivity in the community was 10%. So it's not to say that children weren't testing positive, but when we tried to look at where they were getting their COVID, it was very strongly in favor of outside of the school setting. And so we weren't seeing schools as being hotbeds of transmission at all, and we never have. This is consistent with the data from British Columbia, with British Columbia, where school transmission was around 1% of cases. This is a study also from British Columbia where they actually did the blood work on teachers to see how many might have antibodies to COVID. So even if they didn't know they had it, they looked at what we call seroprevalence. And the teachers were at no higher risk of testing positive for COVID than anybody in the community. So in other words, being in the classroom didn't expose them to huge amounts of COVID, of the virus. And this is very important because the study, this study, for a big chunk of that time, there was no masking in the classrooms of the schools, so the kids were just in the classrooms. So again, not to say that there will never be transmission, but certainly there wasn't a huge amount in the classroom. This is a similar study from British Columbia that again looked at all the outbreaks and transmission, and basically schools, while they happened, they were not a significant contributor to spread. Now, I haven't listed them here in this talk, but I can provide any of these references to anybody who wants them. But every study that's looked at it has pretty much shown the same thing, that schools reflect, they mirror what's going on in the community. They're not amplifiers of what's happening. So if you get high rates in the community, you will see high rates in the school. But in the case of COVID, it's not the children who are the amplifiers. And the other thing to remember about children, of course, is that it's not like they disappear into a black hole and they're not at school. They're still being exposed. And so, again, when we talk about schools and risks, you have to take it with the whole entirety of what that child does 24 hours a day, and not just what happens in schools. But I've listed other countries that have very good school-based studies or risk and teacher studies. So it's the same in England, Scotland, Germany, lots of studies from the United States, Sweden, Norway, Japan, Brazil. We have never found a compelling study to show that schools are amplifiers. This should be incredibly reassuring to us. It's not to say we're never going to have transmission in schools, but like I said, they're more mirrors of the community. The other really important thing to remember for context is that 2 years into this, we're not the same when we first were worried about it, because adults are vaccinated now. And so the potential concern that kids are maybe going to transmit it to adults and somehow add to the burden of disease is really disappeared, because the vaccines do a remarkably good job at preventing severe disease. So I know that if I don't care who's around me, vaccinated, unvaccinated, coughing, not coughing, by choosing to be vaccinated, I actually believe the vaccine will protect me, and so that the concerns about possible secondary transmission are significantly reduced because of that. The other comment I'll make about children is we have really unnecessarily targeted them for testing. So we test children far more than just what any other sector of our society. And we're also testing adults less, particularly if they've been vaccinated. So there may well be a perception of a dramatic increase in pediatric cases because we have a real discrepancy in testing. And it's, again, this testing of asymptomatic people, something we really do need to be moving away from. So Omicron, just because it's the topic of the day, we may well see increases in schools, but of course the huge increases we've just seen in Canada are actually while schools were closed, so nobody can blame schools for that. We can also look at pretty much every other jurisdiction in the world that's had Omicron, and schools were not closed in most of them, and it really didn't matter, they go up and they go down. So again, you know, we need to worry about the overall situation, but there's no reason to close a school or to penalize our children because of that. And even if you do have Omicron transmission, the context is it really doesn't make people very sick, and kids in particular have never been vulnerable to COVID. It's one of the mysteries to me is why we haven't been on our knees thanking whatever we want to thank, that kids have essentially been spared during this pandemic. So, of course, it's not just about COVID, it's what's the result of the measures. Because closing schools may or may not have much of an impact on the trajectory of the pandemic. I think a lot of us think that if there had been a contribution, it was small and certainly not worth the harm that has resulted. And that's really what I'm going to be talking about now. We have an unequivocal, horrendous parallel pandemic of harm that we have done to our kids. And we as a society need to decide what are our focuses, what is most important. And prioritizing the needs of our children, because that is our future, has to be, to me, a fundamental part of public policy. We need to do everything we can to maximize the benefit to our children. And what our children need is certainly not what our seniors need. And a one-size policy doesn't fit this. So we should, I mean, my personal opinion, we should never shut down schools unless there is evidence that there's potential catastrophic harm to children if they go to school. And what we have is the exact opposite. We have evidence of catastrophic harm to our children because we've isolated them. We're seeing, because of the decreased activity, they can't go to school, they can't play sports, they can't go to parks, they're not allowed to have parties, a marked increase in obesity. It's not great. It's a lifetime of health issues if children and teenagers end up with obesity, and we know that this leads to a lot of associated health risks, increased high blood pressure, diabetes, heart disease, high cholesterol, all these things go along with that. So this is setting up our children for long-term health problems. Loss of structure, loss of personal relationships, and this is not benign. Our children, our teenagers, young adults, friends, relationships, teamwork, all of these things are so important for us to become fully functioning adults, and we are completely depriving them of that. Isolation, major increase in mental health issues, increase in drug misuse, and you can see that from the really significant deaths from overdose. And the death, of course, is just the tip of the iceberg, because underneath that are all the people who are probably misusing drug but not dying. Increase in suicidality, lots of potential for increase in violence, addiction in the households, and these are kids that are not in the system anymore. We don't even know what's going on with half of this, but we know that we've seen some very severe abuse showing up in hospitals. Increase in food insecurity, most important on the kids who are already vulnerable in households and families that are already vulnerable. And we can't even touch on things like the long-term harm from an interrupted education and the lost opportunities. Just in Ontario alone, the estimates are that there are over 100,000 children who are just gone from the school system now. Everything that kept them going is gone. They don't really have access to online learning. They don't necessarily have computers or iPads. They might be in an apartment with 3 siblings, all trying to share the same internet connection. and maybe a single parent who's lost his or her job, and then this teenager has to go and get a job. But these are kids who are just gone, and that's their entire life interrupted. And that is, quite frankly, an early death, because we know that socioeconomic status and education and this is how people move ahead. This is how, we become functioning adults. What about the rest of the kids? The lost opportunities, no sports, no hockey, no ballet or dance, no music, no drama. These are the things that allow us to thrive as adults, that are actually give value to the life beyond just the education. This has been removed from our children, and we need to talk about this. This is a study from the United Kingdom looking at language acquisition, so recognition of speech and understanding of speech, both at primary and high school level, impaired. Why? Because there's no face-to-face contact, you can't see the lips move, comprehension is impaired, and increased screen time. This is not a benign thing we're doing. Well, we talked about opioid deaths, far outpaced the deaths from COVID-19. We're all important. This is a very concerning study to me. It's a British Medical Journal. It looked at the cognitive tests that were done in children born in the last 2 years of the pandemic compared to pre-pandemic. And they're scoring lower on cognitive tests, not because they've had COVID, but because we've narrowed and restricted their lives. There's a lot less interaction with adults. When they go out, everybody's in a mask. We're not letting people have play dates. We've got all these sort of rules around who people can see. Maybe it made sense, maybe it didn't for COVID, but it's not just about COVID. It's about total harm minimization, and we should be very concerned at this kind of data coming out. We talked about obesity. Very significant studies, and not just that the kids were getting more obese, but getting obese at a much higher rate. This is from the CDC, this study. The opposite end are the other eating disorders, really almost a pandemic of eating disorders in our hospitals to the point where we actually can't cope with them. Lots of mental health problems. These have been flagged over and over again. But again, we can't just dismiss this, because a mental health issue that starts in childhood or adolescence follows that person for their life. And so it's not just, it's 2 years and they'll get better. Sure, some will, but a lot won't. Recognize that finally in October of last year, the American Association of Pediatric said this is a national emergency in children. They declared a national emergency in children's mental health. And this is Children First Canada. It was from last year. But looking at the 10 top threats to childhood in Canada, and this is recovering from the impacts of COVID-19. So this is a group of experts, pediatric experts, that looked at what is happening to our children, and they've listed them here. This is generational, what we're doing to our children. And yes, we had a pandemic, but we have to deal with the fact that it's not just about COVID, but all this collateral damage, and it is becoming, this is going to be, in the end, probably cause more harm than COVID ever did, and we really, really need to start talking about this. I'm going to switch to what's going on, so it's Canada, but so what's happening in the rest of the world, because is it different? And when I started this, putting this together, I was going to try to sort of put what every country was doing and give people a sense of comparison. I started with Finland, and this is from Saturday, just this past week, that the pediatric organizations there said, basically declared, our estimate is that children will not be the driving force behind the pandemic. All restrictions related to children are de facto ineffective, but the harm caused is immediate and widespread. The hobbies of children and young people should therefore not be limited systematically and without thorough consideration of local circumstances. You will find similar statements from pretty much all the Scandinavian countries. But then I just did Finland, and I realized that maybe visuals would be more helpful to look at what is happening to our children in other countries. And this is, I picked photographs that were really most from 2021, and to the best of my ability from September of 2021 till January of this year. So this is the first day of school, grade 1, September. On the one side, it's actually Kentucky, that photograph, but it could easily have been Ontario, and the other side, Denmark. So our kids are lined up on a line, hands behind their backs, they're not allowed to touch anything, faces hidden. In Denmark, the kids are running in, there's no masks, they've got their belongings, they're allowed to play, they're allowed to interact. Same virus, same kids, but two different approaches to how we respond. And again, these are just random pictures I chose. Here's an after-school program in Virginia in the fall. There's a sports team in Chicago, January of this year. A day school in Florida last year, in the fall of last year. Here's a Georgia school band, fully functioning. There's a group of kids in Illinois in January. Jamaica Day 2021. Here's a kindergarten in Norway, all the kids on the floor gathered together, unmasked teacher, lots of interaction. Open day at a school in the UK. On the top, we have a volleyball team in January of this year. You can see that there's two kids in the background masked, so mask optional, but most are just back to normal. And then a high school in Florida. Here's Red Nose Day in the UK in a kindergarten class. The kids are all in their costume. They're all grouped together. They have their little noses on, but life is normal. And the teachers are, of course, unmasked. We have a school band in North Carolina, and these are some cheerleaders in California. These are just from online. I just did a search to see what's happening in schools in other parts of the world. And then this is Canada. This is a school in Toronto at lunchtime. The kids are masked, they're not allowed to talk to each other, and they're behind these barriers. This picture, I actually found the picture at the top really, really disturbing. These are two little girls who hadn't seen each other for a long time. They're best friends, apparently. They went to hug each other, and what the two teachers are doing are dashing over to keep them apart and make sure they keep that 2-meter distance. We have hand washing is excellent, but like everything, there's a balance. But in the background, you have a child sitting by himself, masked, with a big X in the spot next to him because nobody's allowed to sit there. There's a classroom on the bottom, the desks far apart, the kids masked, all facing forward. And probably pretty horrendous are the kids sitting on concrete, having their lunch at a baseball court. Here's another class arriving in with hands crossed. They don't touch anything, no personal belongings, no facial expressions allowed. There's a preschool. I don't know what they're doing inside those boxes, but there you are. That's what's happening to those kids. And then a scene with kids all by themselves eating lunch. And I don't know why we have visors on children. I mean, these rules are very bizarre. They're not evidence-based. There's no studies supporting it, but that's what's happening. So what's the future for our kids? Are they going to be exposed to COVID at some point? Yes. Is it a bad thing? No. We're all going to be exposed in the end. The issue is, are we going to be harmed by it? And the answer is probably not. Are they any more risk from COVID than anything else we expose them to? No. It's the same, actually, for our children as other respiratory viruses, and the risks are much higher with other things we accept every single day, such as getting in a car. Again, it's not to say that there will never be harm to a child, but we have to put it in perspective. Will closing schools make any difference? Of course it won't make any difference to the transmission of COVID, but it's sure as heck going to make a difference to the harm that we're causing our children. What do we risk by we keep doing this? Well, we're further impoverishing their lives. We're further contributing to social isolation, to depression, to anxiety, loss of opportunities, the harm we're doing to their education. These are not benign harms because of our restrictions. Is there a risk about teachers to parents, grandparents? And I'm going to say again, it's not really a risk, it's risk and benefit. Adults are vaccinated. The vaccines prevent progression to severe disease, hospitalization, and death. I cannot say this often enough. By choosing to be vaccinated, a vulnerable adult can be exposed to a vaccinated person, an unvaccinated person, a child. It doesn't matter who may be transmitting the virus, the vaccine is still going to work for that person. So at this point, is there any benefit in not allowing people to socialize? Is there any reason we would say to a grandparent that they're not allowed to hug their grandchild? The benefit of those interactions at this point, 2 years into this, far outweigh any potential risk. And of course, we can talk about benefits of the extracurriculars. I mean, these are really important. These are the activities that enrich our lives. These are activities that allow us to bond, that allow us to become whole functioning adults. Just so you don't think it's just my opinion talking about extracurriculars, this is a study that the Southeastern Conference of Football group did. It was a huge study. Because in 2020 there's some concern that maybe football was a high risk, what they did was they actually put monitors and remote sensors on every player, and then they analyzed every single interaction that had happened, and they tested every player with a PCR 3 times a week. There was not a single instance of in-game transmission. These are not high-risk activities. We should be letting our kids just play outside. Going back to schools, are they safe? Well, they've never been shown to be unsafe. Do our teachers and kids deserve well-maintained, well-ventilated facilities? Of course. But that doesn't mean that we don't let the kids go back to school. It means that we acknowledge that some of our facilities are old and need to be upgraded. And I don't know why we're wearing N95s and eye shields in schools. There's not a single study that would warrant this. It's not based on any data whatsoever, and I don't know why we're doing it. I don't know why we're sort of have decided that this precautionary principle is degenerate to the point that we're allowing fully vaccinated, low-risk people to be wearing N95s. And so I realize that my opinion might be a bit controversial, but I really feel for putting in interventions like this, it should be based on evidence. I'm going to touch on masks. Do kids need masks? Well, believe it or not, there's not a single study that shows that they benefit. The United, at least in schools with young children, and remember, I'm talking about kids. The UK actually did a really detailed review recently, and anybody can look up this report, the reference is there. They actually concluded that maybe in older kids that there might have been a small decrease in transmission, but it wasn't particularly significant, but the data were inconclusive. So even when they looked at all of what they had, whether or not school masks on kids in schools made any difference was very unclear. The other thing that a lot of us may not realize is that it's actually not the norm to mask young children. Most countries have never masked children under the age of 12. And it's a very difficult conversation to have in Canada. We've become so polarized that if you try to ask questions or try to have sort of targeted interventions, you immediately get labeled either you're pro-mask or you're anti-mask, and nobody's allowed to be in between. And I think we should be in between, actually. We should ask questions. Why, if you look at this is a list of the countries that mask young children. The much longer list of countries that have never masked young children, and a few where it's in certain, at times in certain areas. Are the kids in the other countries worse off than ours? Well, the answer is clearly no. And if they're not, why are we doing it? This is a story that actually got sent to a friend of mine today. Actually in Ottawa, he sent it to me. This is a mother who said, my son went to school, this is from yesterday, but my son went to school today outside of Ottawa, 8 years old, beyond excited to get back into the classroom and see his friends. He came home miserable, can't talk to his friends at lunch, was not allowed to leave his seat the entire day with the exception of going to the washroom. And due to the weather, they didn't go outside. So 6 hours of not moving out of his seat. All this to make classrooms safe, and the teachers wearing N95s and face shields. We need to stop. This is not rational behavior anymore. Children are not at risk. We're not seeing transmission in schools. What is unsafe in this setting is how these children are being treated. If we had done this 3 years ago to our children, we probably would have labeled it child abuse. It would have been shocking that anybody would behave to children the way we are currently accepting. I'm going to move to vaccines quickly. So vaccines are excellent. They're one of the miracles of modern medicine. The perfect vaccine stops every evidence of clinical disease and all transmission of the disease goes away. This really seldom happens. So then what we need to do is prevent clinical disease. At a minimum, and that's what most vaccines do, somewhere in that category B. But some vaccines don't really stop transmission, but they do a very good job preventing severe disease and death. And that's where the COVID vaccines are. Very good at preventing severe disease, hospitalization, and death. Unfortunately, and I think to a lot of our disappointment, they're not so good at stopping transmission. So we have fundamental intervention that has fundamentally changed what we're dealing with in terms of that decoupling of cases from hospitalizations. But clearly, we're going to see this impact most on the people who are most likely to land in hospital, which is our seniors. The benefit as we go down the younger age groups is nowhere near as pronounced. And that's not surprising because, for example, a young person is so unlikely to land in hospital in the first place that though the vaccines will further reduce that, we're going from very low to very low. Clearly seen in the data from Denmark, unvaccinated 2 doses and a booster. You can see very clearly that in the youth, they don't vaccinate the 5 to 11-year-olds. So that's why it's the 12 to 15. There's a slight spike if you look at the 12 to 15 and unvaccinated, but where you can see a clear benefit of vaccines is as we move into the older age group where people who are about 50 up, there's really a much higher chance of landing in hospital if a person has not been vaccinated. And this is where the benefit for the vaccines is most pronounced. And of course, this was recognized by NACI, our National Advisory Committee on Immunizations. Again, this statement is available online. If you just look up NACI COVID-19 recommendations for children. I won't read the whole thing, but I think the most important part is the last sentence. It says that, given the short-term uncertainty surrounding pediatric vaccination at this time, children and their parents or guardians should be supported and respected in the decisions regarding COVID-19 vaccinations for the child, whatever decisions they make, and should not be stigmatized for accepting or not accepting the vaccination offer. This is our National Advisory Committee on Immunizations. This is what they came up with after reviewing the pros, the cons, and everything we knew. So I can't emphasize enough, I'm a strong believer in vaccines. I have been giving vaccines to people since February of last year, the COVID vaccine. But I'm also going to be honest about the very good parts and the areas where there's still questions. We have seen waning immunity at 4 to 6 months. Is this going to happen in children? We actually don't know that yet. We're still figuring that out. We've seen very good protection against severe disease even as antibodies levels wane. Is this going to be the case in children? We expect so. And that would be a good thing, regardless of what the antibodies show. Certainly, we clearly have a cell-mediated immunity that kicks in, and that's why protection against severe disease is maintained. Will this be the same in children, particularly as we're giving them the 10 microgram dose instead of the 30 microgram dose? Probably, but again, we're learning. We've only started to vaccinate young children since November and teenagers since the summer. We're still collecting data with regards to the safety in terms of risk of myocarditis or pericarditis, which we definitely are seeing. It's rare, but it's very real in teenage boys and young men mostly, though it's sometimes in girls and young women. Other possible adverse events. Overwhelmingly, they seem to be well tolerated and very safe vaccines, but we're still learning about some of this stuff and how frequent they are. Other uncertainties. Will children benefit or need a booster? We don't know. They have very strong immune systems, so they may not even need one. And certainly this is what World Health in Europe is saying, that there's no role for vaccination of teenagers. So again, we have sort of different recommendations coming out depending where you are. And then what would the ideal time be for a booster? Is it at 1 month? Is it at 3 months? Is it at 6 months? Should it be seasonal? We don't know, and we should be learning this. Do people who've recovered from COVID require a vaccine? We're certainly doing that in Canada. But again, what's the best time? Even though we don't talk about it much, we have many studies showing excellent immune response after infection. Certainly it's very robust still by the 6 to 8 month mark. So what's the best timing if we're going to vaccinate post-infection to do it? I've seen some recommendations say 1 month after a person has COVID, which I have to admit, I don't know what that's based on because it doesn't make a lot of immunological sense to me. Are we going to see increased adverse events with the boosters? We don't know. Will we see diminishing returns with the booster? Maybe. We're seeing that in adults, actually, and this is flagged already in Europe, that too many boosters too close apart may actually end up with a weakened immune response. So again, not to say the vaccines aren't valuable, they're an incredibly valuable tool, but now that we've got this great tool, now that we've had a dramatic decrease in hospitalizations, we can fine-tune and hone how we use it and maybe have much more targeted recommendations. Should children be vaccinated? Any high-risk child, any child may be in a high-risk home, but after that, as far as I'm concerned, it's entirely by the NACI guidelines and in line, quite frankly, with pediatric policies of pretty much every other country. In other words, if a family chooses to be vaccinated, that's great. If they choose not to be vaccinated, we respect that. And this is for the COVID vaccine as these uncertainties and as these questions and as we learn, as we roll that out. End goal of vaccination really depends on what we're trying to do. Are we trying to stop all severe disease, hospitalization, and death? Because if that's our target, we're there. In Ontario, we have maybe 200 people not vaccinated in ICUs out of a population of 14.7 million people. That is a burden we can deal with, and it's no different than influenza or anything else. But if our objective is to stop the virus entirely, that's not going to happen. We already know that the vaccines, while they protect against severe disease, are not stopping transmission of Omicron. We just have to look around to realize this. And studies from California, from Denmark, and from Ontario have all shown this, that people aren't landing in hospital, but there's very much ongoing transmission. I won't go through these actually, but these are the studies that show decreased or waning immunity. This was the California. The red line is sort of, you can see at 6 months that really don't have a lot of protection against ongoing transmission. This is from Denmark, where within a household, pretty much everybody, if they're exposed, gets it. And this is from Ontario, where again, if you look at the little bars, the sort of the more gray-blue ones, that the effectiveness against Omicron transmission is not great. Which brings me to mandates. If we're going to talk about a mandate, we have to have a very, very clear public health objective, because the primary benefit to an individual is clear. But if we're mandating or we're requiring something, we need to have really good evidence that it's going to work. We know that we're keeping people out of hospital. We know that we're pretty much there. And we know it's never going to be zero. That's an unrealistic expectation. But when we talk about kids in particular, if the vaccines are not stopping secondary transmission, which they're not, then we need to know why we're doing this. And it cannot be because of coercion. So I think that I personally am very much against mandates, because I haven't seen a good public health reason for doing this, because we're still seeing transmission. That's why we're shut down in Ontario, obviously. I also would like to say I don't think individual organizations should be allowed to just create their own rules, especially if there's no clear public health benefit. So hockey groups or schools or school, I'm sorry, but we need to respect NACI. I'm not going to talk about treatments, just that they're available. So if a person has tested positive for COVID, they shouldn't just go home and isolate. They're allowed to call their doctor and figure out if they qualify for early treatment. This is the newest drug that's available, but we don't know much about it yet. So I have a little bit over time, so I'm going to go quickly here, is shifting from pandemic to endemic. We need to learn how we're going to live with this. We have a population immunity now between people who have recovered from COVID, who have been vaccinated. And the end of a pandemic, interesting, is not just severity of disease, but it's also us coming to terms with it. In terms of disease severity, we're already there. COVID is no longer causing more severe disease than pretty much any other virus, and these are the numbers if you look at pediatric admissions. In the UK from the beginning, 15,000 from COVID, but way more from other normal viruses. And then you can see from the table that normally we see way more respiratory admissions. I'm going to end with some final thoughts. Is COVID just another coronavirus? I think it's just our 5th coronavirus now. It's not to minimize the last 2 years, but we're in a very different position. We have a high degree of population immunity. We have a much better understanding of early treatments. And our hospital capacity is not because of patient volume. It's a lot of other issues, including staffing shortages. So we really need to pivot and look at where we're going to move forward. We need to start talking about this. We need to allow debate and discussion. Lots of misinformation on both sides. We need to meet in the middle. We need to have conversations about repair, about recovery, about moving forward. We need to validate people's experiences of collateral damage. And for me, can we stop blaming people? This is nobody's fault. It's not the fault of a vaccinated person. It's not the part of a vaccinated person. It is unquestionably not the fault of our children. It's just a virus. So my final thought, and I'm sorry I'm over time, is an article in the BMJ, British Medical Journal. The end of a pandemic will not be televised. As an extraordinary period in which social life was upturned, the COVID-19 pandemic will be over when we turn off our screens and decide that other issues are once again worthy of our attention. Unlike its beginning, the end of the pandemic will not be televised. And as some of you may have heard, this is what happened in the United Kingdom today. They've just decided to move on. Thank you, and I'm sorry I went over.
That was an excellent presentation. And again, it's the whole essence is let kids be kids, the untoward effects of the COVID. We need a balanced approach. And is it time to pivot? And we're also not only doing the physical aspect of COVID, but we're also going to be talking about the mental aspect and some of the complications of. So before we start the panel, and we have an esteemed panel today, we've got Dr. Boylan, who is a pediatric psychiatrist, associate professor. And we've got Dr. Fulford, who we've just heard, and we've got Dr. Dennis DiValentino, a family doctor, and who will share their experiences and review the questions. And I'd like to thank everyone here because this is an important topic. This is going to impact our next generation. And my concern is that the COVID pandemic will resolve. But what about the implication? What about the long-term effects? So I think it's important now that we deal with our kids, that our kids are back in school, but more importantly, they're back in extracurricular activities, they're back with their play days, they're back doing things that kids should be doing. So let's start reviewing some of these questions. So by far, the number one question is this. How will we ever repair the discrimination and divide that has caused with children? Example, unvaxxed can no longer attend sports games, movies, summer camps, play dates, etc. Unvaxxed are shunned, singled out, and bullied at school. And that's sort of, I'd like to turn that over to our pediatric psychiatrist, Dr. Boylan. And what's your take on this? You're still muted, so let's turn that question to, we'll get back to you, Dr. Boylan. Let's turn that question to Dr. DiValentino. What about the kids? The kids, I'm not, Dr. Fulford clearly stated we should be following the NACI recommendations. These are the national recommendations and led by a scientific body. And clearly they say that it should be up to the child's and parents' choice for vaccination. Well then, how can we impose restriction on these children attending extracurricular activity, be it hockey, swimming, ballet, etc.?
Yeah, I think that Dr. Fulford really did a good job of touching on that. And the question brings out the aspects of polarization that have come about. And polarization on just about every topic in the pandemic, but probably at the top of the list is vaccinated against unvaccinated. And I think it's important to recognize that we are just not seeing the evidence that somebody else's vaccine status has any implication for you or anyone else other than them. And so I think part of sort of moving forward is to recognize that we need to restore choice. We need to restore choice. We need to restore autonomy. We need to stop being so polarized and start having discussions that start moving us closer together. We have to stop with black, okay, white, up, no down. And the answer, like everything, is somewhere in the middle. And so if we start doing that, I think the best way to repair this particular problem and what children may face there is to eliminate it. And I think that we could do that because it occurs to me that's exactly what we've been doing right up until the start of the COVID pandemic. And so I hope we can get back to that.
Okay. Dr. Boylan, are you back?
I think I'm back.
Yes, perfect.
And I completely appreciate everything in medicine and in life is about finding the middle path. Nothing is one extreme or the other. However, we need to do just as you said, but I think we also need, as a society, to advocate to our government officials that they need to change the messaging about these restrictions on children. And we have to be desperately careful about paying attention to the impact of the harms that have already happened and actively doing something about it. And talking about getting vaccinated is not step one anymore, at least based on the evidence. And that information has to get out. We can't just talk about it today. So we encourage people to share what they've learned today and also to speak to those who they know who have the ability to make decisions and influence government. This is very important.
Thank you. Now, Dr. DiValentino, why aren't scientists speaking out on this?
Yeah, I think that's an important topic, and I think to a certain extent Dr. Fulford has touched upon that. I think there's a lot of fear about this concept of disinformation, and this has become something that's a little bit confusing for a lot of scientists because we're used to debate and we're used to discussion. And anyone in the practice of medicine or science is aware that that is how we got here. It really is centuries of debate and discussion. And so the concept that one particular opinion represents information while another represents disinformation is very concerning for scientists and not something that we're used to. We certainly recognize the need for a uniform message when it comes to something like fighting a pandemic. We also have to remember, and I'll use one of my favorite quotes here, and that is, science is in trouble when the will to believe is greater than the duty to doubt. And we have to understand that the duty to doubt falls on physicians, it falls on scientists, and it's our job to doubt on the public's behalf the fact that while the vaccine, as we heard from Dr. Fulford, has been very effective on many fronts, it's our job to doubt whether or not it will be perfectly safe and perfectly effective on all fronts, in all individuals moving forward. And you need us to do that on your behalf. And so I think that scientists have not been coming out because they're fearful that this duty to doubt will be confused with either an anti-vaxxer or just generally a non-cooperative or a disinformation-based approach. And in answering the question, I do want to comment on one scientist in particular that I think really took a step forward before many other scientists were willing to do so. And he spoke on behalf of our children and the safety of our children, and he had concerns about our children. And I think he's done a great job as a scientist, and I think he's been unfairly treated, and he's been labeled as sharing disinformation or disseminating disinformation. And I've been doing my best to follow very closely to see if that's the case. And in my opinion, as a physician, it simply is not. And that's Dr. Byron Bridle. And I want to say, both as a physician and as a parent in this country, and I have a 6-year-old who's almost 7. I want to say thank you to Dr. Bridle for being the first who was brave enough to step forward. And I hope he continues to do his work. And I think that the rest of us will take something from what he's done in terms of following along in refusing to not have these discussions. We're going to have them. We're going to be balanced. It's going to be science, but we're not going to stop.
Thank you. So what we're hearing now from Dr. Fulford's description of the virus, it's a virus. It may not be as impactful as the current viruses like the flu, pneumonia, RSV on children, but now because of the lockdowns, the restriction in children activities, children not going to extracurricular activity, not seeing their grandparents, what about the mental effect or cognitive effect or psychological impact on these children? And I'm talking about not only today, but will there be a long-term impact?
If I can speak to that, I feel that we know now that there is a current impact. And the crisis currently in Ontario around child and youth mental health is that while we were worried 2 years ago about keeping patients not sick enough to be in an ICU, we now have a different problem, which is trying to find a way to care for the teenagers that are in the ICU because of suicide attempts and drug overdoses. This is the tip of the iceberg, though. There is an unprecedented increase in families and youth reaching out for help. And we are, just like we were maxed out initially with COVID for emergency rooms, we are maxed out in terms of our capacity as child and youth mental health treatment providers to meet the need. So we are really worried about this. And because of child and adolescent onset of mental health struggles, unfortunately, it takes years to help undo some of the harm that comes from these types of illnesses. And so we don't want to get there, but we know we will because we've started to see an increase in the number of people reaching out for help. So in my mind, we need to be very careful because this is the next pandemic. It will be a mental health pandemic, and it will last 4 years. So we need to figure out a strategy to start working on it like last year.
Okay, thank you. One of the questions here is a bit controversial. It says, why is it the politicians and authorities don't seem to listen to you, the real experts? Now, who wants to take that? and I had to ask that. It's like the top question here.
I'll take it. Well, I'll start anyway.
Okay.
I actually don't think that the current government, and we're going to speak provincial, right, because that's really the area that we should focus on, and that's where our experience is.
Having said that, the NACI is national guidelines. Shouldn't we have a national policy?
Well, the challenge is, and now we're getting a little complicated, the challenge is it's all different healthcare systems, but yeah, I think more uniformity in some of these guidance policies would be helpful. But I don't think that the government is not listening to doctors. I think that the current government, especially in our province, is struggling to find dissenting opinions from the ones that they're hearing from. And I think they're doing nothing but listen to doctors. And I think it's important that if there are quote-unquote dissenting opinions, and this is not to suggest that others are wrong and that, people with a counter opinion may be right. These are questions about whether or not we are doing things exactly right or if changes should be made. And I think if some of those voices were heard by the current government, I think that they would probably take that into consideration. They just haven't had the opportunity to hear it. And so I don't think they're not listening. I just don't think they have enough to listen to.
Does anyone else want to add in on that? Okay.
I was going to say, just from the perspective of child psychiatry and allied health professionals, we are so busy with direct patient care and risk management that I would argue we're not really thinking politically, and we need to do more. It's just that we are preoccupied with the needs of patients right now.
So a question that's arisen is where kids are kids, and we're talking about our high school, our grade school, high school, but what about our university kids? Our kids have been now like 2 years COVID, and they're going to be graduating next year. What is the long-term implications on them?
I mean, I can start. I think it's the same, actually. Some will be okay, but quite frankly, isolation, online learning, when young adults, social interaction is still critically important. This is when we make, permanent friends for life. It's when we have relationships. It's when we learn, intimacy, where we learn how to break up with people, get back together. It's how to do teamwork. This is again part of normal human development. And confining them to rooms and denying them that social interaction is not normal. We've also deprived them of a lot of the opportunities to excel in other ways, and we've talked about this with the younger kids, but again, it's the sports, it's letting people excel in their music, letting them excel in all these other activities. Kids in Ontario are not going to be able to compete to the same extent as a lot of kids internationally from the US where they didn't have these restrictions. And I actually have no understanding, for example, why the media only reports the worst case scenario and doesn't report how many places in the world are back to normal, because it gives a really false impression of how bad it is. And we've, for some reason, and misinformation is bad. Don't get me, I actually, the disinformation on minimizing COVID or saying it doesn't exist or saying the vaccines do nothing, this is misinformation. But there's also misinformation at the other end that we've never tended to call out, and I'm not sure why. Yeah. And I think maybe because people didn't want to somehow dilute the message of the pandemic or something. But the people who exaggerate the harms, who exaggerate the need for these measures, who are simply not talking about this middle ground, to me, both extremes are sources of misinformation, and it might help if we could meet in the middle, because the harm to young people, this is not just our schools and high schools, it is university students. And if you try to ask people, why are you doing this? Why are we isolating them? Why is anybody wearing a mask anymore if they're at no risk and our vulnerable people are vaccinated? There's no really good concrete answer anymore. We're just doing it. It's almost like we're doing it because we want to do something. And maybe we'll say that it's okay to keep doing this, but we should be asking these questions. It should be okay to meet in the middle and have a debate. Why are we having our kids and teachers in N95 masks with face shields and not letting them eat together when everything's wide open in over 50% of the United States, when the UK has completely said, okay, we're finished with this, we're moving on? We should be allowed to talk about this, because our measures now, to me, are out of proportion to any conceivable threat and are not based on any, I'm not sure what they're based on anymore, but it feels like the misinformation on both sides. And whoever asked that question, I don't know. If I knew why we can't have civilized debate and meet in the middle, I don't know, but I wish we could.
Totally agree.
There's one organization, I guess, Dennis, you're telling me in Alberta was, what's it, Parents for Choice?
So it's Families for Choice. It's a really great organization, and it started by a group of Calgary moms, and I just wanted to mention them because I had a really great conversation yesterday, and I think their initiative is fantastic, and they are entirely focused on two things, and I think it's the two most important things that we face right now, and that is they as well believe that we need to put the kids again first, and that we need to restore choice and autonomy, which is like a fundamental underpinning of our society that's been absolutely wiped away in the blink of an eye, you know, under the guise, and maybe not at one point with the guise, but now we do not have a rationale to do that, and we need to, you know, go back to who we are as Canadians. And I think that's what this group represents, and so I wanted to mention them.
Yeah.
It's Families for Choice, and they're fantastic, and I've signed up and become a member, and I recommend others do too.
Excellent. Now, a question that's come up is, what about, again, it's about this mask issue. This is like a burning issue. So the question is from Steve. My daughter is a teacher in grade 3-4. How important is mask wearing for A, her as a teacher, she's been vaccinated, and B, for the kids? And then the second part of that question is, not all the kids have been vaccinated. Is that an issue?
So I actually will go on a limb and say I think we have no evidence at all anymore for masks in schools on children. As I put in the presentation, we are in the minority of countries that are doing this. It's actually not the standard, and it's specifically recommended against by the World Health Organization and the European Union CDC, that children under 12 should not be masked. We have no trials showing that it's effective. We are just doing it, and it's like we can't. And I think it's hard once you start to doing something to stop doing it. It's always easier to not do something than to say, well, you know what, maybe it wasn't right, or maybe we don't need to do that anymore. You know, I think probably the obvious first step is to make masks optional for people. So some people are going to be more comfortable with them, some not. But honestly, I don't know why we're masking kids in classrooms when this is actually not the standard internationally. Yes, there's some jurisdictions doing it, but there are many who are not, and those kids have all been fine from the COVID perspective and probably a lot better from the mental health perspective. In terms of why a fully vaccinated person is masking, again, I think as a society we need to ask, what is our end goal? I am very comfortable that by choosing to be vaccinated, I pretty much reduce my risk of ever having severe outcome. Will I get COVID? Sure, I think all of us will. Am I worried? No, because I don't think I'll get very sick. I believe that vaccines work to prevent severe disease. And sometimes I feel like I'm the only person left that believes it. When I look around me, I think all these vaccinated people behaving as if we're at the very beginning of the pandemic, I think, I don't understand. I actually think they work. I think we can see it from the decoupling in severity of disease. I think we can see it from other countries that if you got vaccinated, you're probably not going to land in hospital. It's not going to be 100% guarantee, but it's pretty good. And that's mostly for vulnerable adults. I'm an older adult, believe it or not. I mean, we all age, it's inevitable, but there you go. Right? But I think it worked, right? Do I think a kid needs to be vaccinated? I respect entirely the NACI guidelines. I think they did a good job. I'm also well aware that most countries have not recommended this for children because the risk of COVID, if that child gets COVID, is really very, very minor. They will get immunity to it. So I think it's time to ask these questions. I think it's time to have conversations moving forward. I think it's time to pivot and say, guess what? We did a really good job with the vaccination programs. We've done a phenomenal job decoupling. It's okay to start to peel back these measures. So I personally don't think it's a problem if they don't wear masks, but I realize that's highly controversial. And that's not because I'm an anti-masker from the beginning. It's because I'm saying pragmatically right now, why are we doing it? What is the public health reason that people are still wearing masks? And we need to answer that, and we need to have evidence as to why we're doing it when most places are not anymore.
So I've got an important question for you, probably the most important. My granddaughter Avery is going to be 4 in another week or two. Can she have a birthday party?
Absolutely, she can have a birthday party. I'm not public health, so obviously I can't speak against public health guidelines, but if you ask my opinion, 100% that child should have a birthday party, and they should be allowed to play, and they should have no mask, and they should be allowed to hug, and they should be allowed to laugh, and they should be allowed to see smiles. Absolutely, we should be bringing smiles back into our lives. You bet. Have a birthday party.
Thank you very much.
My son, whose birthday is in 3 weeks, would be very happy with you. And I think you might need to catch up because, like your grandson Owen, I think he stalled at 4 without birthday parties through the pandemic.
So if he's at 4, the last one he's at 4, so that means he needs like 2 birthday
Yeah,
parties.
it'll be a triple this year. Yep.
Okay. Now, Martha, I know that you're a strong advocate for vaccinations. You believe it, especially in the vulnerable populations and in seniors or people with comorbidities. You actually go in the homeless shelters and you give vaccinations in your own free time.
Yep.
So having said that, do all kids need to be vaccinated?
I'm going to say probably not. And I realize that's very controversial, but when we think of vaccines as a tool and a highly effective tool, it is not uncommon to have targeted recommendations. And so what we did at the beginning when we were trying to sort of stop the severe disease was the right thing to do. It doesn't devalue the role of the vaccines. I think they're critically important. But it's the uncertainties I'm saying. So we know, for example, that we have some recommendations for people who are 50 plus. We have some vaccine recommendations for people whose spleens have come out. We have certain recommendations for people who post-transplants. We have different recommendations for younger people. So having age-specific and vaccine-specific recommendations is pretty standard, actually. And so what we did at the beginning, I'm not criticizing. I think it was the right thing to do to have rapid approval, particularly for the people who are landing in hospital. I think it made a massive difference in the impact of what COVID was doing to our population. But that doesn't mean that we can't stop and say, okay, we've done this. We're in a superb spot in terms of vulnerable adults being vaccinated. And now say, okay, do we have to just broadly do everybody, or are we allowed to sort of stop and look at what the FDA said, look at what NACI says, look at what other countries are saying, and take this tool of the vaccines and hone it and have more fine-tuned recommendations, because this is going to be going forward as well. And we do need a long-term strategy. And so I think, honestly, the speed with which these vaccines were developed and distributed is really quite phenomenal. I did not expect it to be this fast. I think they've been great. But that doesn't mean we can't stop and say, okay, let's figure out now next step and how to best utilize them. And when you're thinking of cost benefit or risk benefit, when I say cost, I'm talking about so that the good effects and possible not so good effects of something. With a child who's at such low risk of disease in the first place, we should be studying how robust natural immunity is. So people who've had COVID recover, it shouldn't be taboo to ask this question. It's true of every other infection, is actually looking at protocols and regimens and schedules for this. And so will every child need to be vaccinated? Probably not. But I might be a minority in this, and I don't think what I'm saying is misinformation. What I'm saying is pretty much in line with almost all of Europe. But we're in I feel that having an open debate and being open-minded and having conversations about how we roll something out is not necessarily the wrong thing, particularly given where we are now in terms of how high our vaccination rates are in adults and vulnerable adults.
Dr. DiValentino, would you like to add to that?
Yeah, thanks. I want to comment or piggyback on Dr. Fulford's comments about the risk-benefit discussions that we've been having. And at least since I've been practicing medicine, which is 12 years now, We are well into patient-centered medicine, and that is where the patient makes the decision, not the physician. And our job is to lay out the information about the risks versus the benefits of a treatment and allow an informed patient to make that decision. And so when parents are looking for a recommendation, what I really want to do is practice the way that we've been practicing now and the way that I was trained, which is to have a risk versus benefit discussion and then empower the patient to make the decision on behalf of their child. And so I'd like to get back to that where the risks and the benefits are both being described in terms of medicine. That's not what's occurring right now. The discussion that I'm having is, what are the benefits of vaccination? And we can lay those out. When it comes to children, we're not so sure because it's a reduction in hospitalization and severe disease that may not be all that significant at baseline. But when I come over to the benefit discussion, I'm usually talking about the ability to carry on interacting and participating in society.
So really,
And that's not a medical risk-benefit
No.
discussion, and that is not patient-centered medicine.
so what's really happening is it's not a medical discussion, but it's a policy discussion.
It's a policy discussion, and we're not the ones to be doing it, and that's right.
Yeah.
I agree.
So Dr. Boylan, what really concerns me is we're addressing what's happening with the COVID and this COVID one day hopefully it will come to an end. But my concern is what I'm hearing from you is this is just the start about the COVID negative implications, negative impact, that the damage is done, and we have to be really aware and put resources and try to address it. What can we do now?
Yeah, we actually haven't talked much about school. And I just want to say that I think if there's anything that we've learned from the pandemic that's been good is how critically important school is and our education system for meeting the needs of children. And I think we took it for granted. We can't take it for granted anymore. We really need to stand up for our schools and speak to resourcing them as much as possible to address the, I don't want to say all harms, but address the impact of COVID. So we're going to have a lot of kids needing to catch up academically. We will definitely have kids that are struggling with reintegration, particularly at transition points between school, like between junior high, high school, that kind of stuff. And we need to recognize that there really isn't a lot of wiggle room in terms of upping school supports because of finances. So that is something that as a society we have to be aware of. So that's going to come back on families in a different way. And families need to be vigilant about this, meaning how can they help fill some of the gaps? Our society needs to think about how to help fill the gaps as well, because as we know, parents are completely overrun most of the time right now. So I think as a society, we need to be aware that this is the next pandemic that we all have to wash our hands and get our hands dirty about, actually. And that is stepping up for our kids, looking for opportunities to help provide them with financial supported extracurricular activities, opportunities for being around other kids and getting more learning outside the classroom. And then in terms of mental health services, we have to be vigilant about our community mental health providers. And there are agencies in Canada that do connect families and teenagers with mental health supports. And those agencies are going to be, or they are completely overrun currently. We need to have more people that help with the transition to accessing lower acuity mental health services so that that burden doesn't specifically fall on physicians, because there's not that many of us anyway. So I would strongly advocate to government and to the community to focus on making access to mental health supports better. You don't have to go the whole gamut and change the system. But at the entry level, we need to be able to have more people speaking to kids and responding to the need that is going to come their way.
Okay, thank you very much. Moving forward, I'm wondering if we could sort of wrap up now and maybe last thoughts or last words. What would you like to share with with the mums out there and the dads, and these are concerned Ontarians and Canadians that you're going to be addressing right now?
I'm going to advocate on the school side, honestly. I think a lot of the measures we're doing now are incomprehensible. I just got an email earlier today about somebody who, the kids are being told they have to sit at their desks, they have to sit forward, they're only allowed to take their mask off, put a bite in, and put their mask up, and they're not allowed to talk in between. We need to stop this. It's not evidence-based. It's not based on anything. It's punitive. It's cruel. It's nothing to do with the virus anymore. And so as parents, as advocates for our kids, I think it's just polite pushback. Don't put in measures because of the fear of the most scared of our population. Can we go back to evidence-based, to what we're trying to achieve, to what exactly the point of all of this is? Because why is a child in Ohio playing full unmasked volleyball and our kids are chained to a desk, not allowed to talk to each other? We need to start pushing back. I mean, not to be rude, not to be aggressive, nobody deserves threats, but these measures on our children, I'm going to advocate that we all start to speak out, that if it's wrong, it's wrong. And I think we all know it's wrong, and we need to start saying, stop. The teachers are vaccinated, the adults are vaccinated. Please let the kids be kids. Let them be free. And that would be my plea.
So it's a balanced approach, and it's time to pivot. Dr. DiValentino.
Well, I think my parting message is definitely in line with Dr. Fulford's, and that is, of course, we have to put the kids back at the front of the bus, or the first thing that we are considering with the next steps in our pandemic. And maybe it's cliche, but these children are the future of our country, and it's time that we start acting like that. And the second thing that I'd like to see is the restoration of choice and autonomy and some of the fundamental things that really made us Canadian before the pandemic. I really want to see those things come back.
Yeah, and the issue, as Dr. Fulford came up with, is when it comes to our university kids, our kids now are not competing, not provincially, but nationally, but globally. And if they fall behind the education, this is going to have a lifelong impact. If our kids are sitting at home, inactive, become obese, this has a lifelong impact. If they develop mental health issues, again, a lifelong impact. And what really struck me was the conversation we were having between the break, and you're saying an 8-year-old, you were in contact with an 8-year-old in your practice, and she was describing to you that she was having anxiety.
Yeah, in those medical terms, and actually described quite articulately, which is not a good thing, a lack of hope.
Now, 5 years ago, would an 8-year-old know what anxiety was? Dr. Boylan, parting words?
Agree completely. We know that the mechanism for mental health difficulties results from kids not being able to do what they want to do to self-actualize. And so if we have taken that away from them, we need to put it back in there so they can make the most of their lives. If they can't get back to a new normal, then that means that this child has had an effect on their mental health. And I would urge parents and teachers to be really careful for that. After kids are back, allowed to do more things, is your kid doing that? If they're not taking advantage of the reduced restrictions, then be worried about that and speak to them about their emotions and whether they may need some help. It's got to be on our radar, or otherwise we're going to have many more problems than we have right now.
So with that, I'd like to thank all of you for spending time with us today on a crucial issue that's going to impact the next generation. I encourage you to send your friends to banty.com/COVID and download the video. And also have to set something straight here. Now, Dr. DiValentino was talking about one of his children, but he has two. He has a 5-month-old, and the 5-month-old is here in the studio. So, again, this is an important aspect. We have to make kids kids again and take away all this burden, all this anxiety. So thank you. Thanks our panelists, and have a great day.